I would be presenting this abstract. It was presented in ELCC 2022 this year. This is concurrent versus sequential immune checkpoint inhibition in stage 3 non-small cell lung cancer patient treated with chemoradiation. So we know that in stage 3 non-small cell lung cancer who are having unresectable disease, the concurrent chemoradiation was the standard of care for long period of time until Pacific trial came, which showed the data about consolidation with immunotherapy, that is durvalumab, and which has shown improvement in PFS as well as OS. And obviously now we saw the data of other immune checkpoint inhibitors like sugammalimab or nivo-ipi combination, which are coming up. So the premise of consolidation with immunotherapy is probably being increased PD-L1 expression after concurrent chemoradiation, and on which the immunotherapy drug acts. But now people are trying to find out whether the changing the timing of immunotherapy can help us improving the outcome in our such patients. So this study, this was a prospective study. The study duration was between January 2016 to December 2020, and 39 patients, all very small data set, 39 non-small cell lung cancer patient of stage 3. And they were divided into two cohorts. One was the sequential lower one was the sequential immunotherapy cohort, where the standard of care, the sequential durvalumab was given. 28 patients were there. The experimental arm was simultaneous immunotherapy cohort, where 11 patients were enrolled. They received concurrent nivolumab along with chemoradiation. And it was after the end of chemoradiation, they were given nivolumab up to 1 year. So there were 11 such patients. And the therapy-associated adverse events were monitored weekly during chemoradiation. And after end of chemoradiation, it was monitored at 6 weeks, then 3 months, 6 months, 9 months, and 12 months. So what they found out, although in this abstract they did not mention about the dosage of nivolumab, so I could not, and even I could not find what was the dose which was used. The results, the median follow-up in the overall cohort was 27.2 months. In the simultaneous immunotherapy cohort, it was 33 months, and sequential, it was 24 months. Median OS was not achieved in any of the cohort. The median PFS was 22.8 months in the simultaneous immunotherapy cohort, and it was not achieved in the sequential arm. PFS at 12 months was higher in the simultaneous arm, 82% versus 63%. But at 24 months, it was opposite. 44% in the simultaneous immunotherapy cohort and 59% in the sequential. So basically, the data set is very small and the numbers were non-significant. So we do not know how we should interpret this. But obviously, as of now, we cannot say which one is superior. And as of now, we have the phase 3 data with Pacific trial. So obviously, the sequential immunotherapy seems to be the standard of care, and that is going to remain there. These are the survival curves which showed the OS and PFS, the non-significant difference between the arms. Now coming to the safety profile, the 18% of patients in the simultaneous immunotherapy cohort developed grade 3 radiation pneumonitis and 14% in the sequential arm. So although statistically there was no difference, but obviously numerically there was higher amount of radiation toxicity in the simultaneous immunotherapy arm. So they concluded that the simultaneous as well as sequential use of immune checkpoint inhibitors shows a favorable side effect profile. What they wanted to test whether concurrent immunotherapy can help us getting the better outcome, but they did not find so. And there was non-significant increase in grade 3 radiation pneumonitis. So I just wanted to give you some perspective about combination of radiotherapy with immunotherapy. There are still certain challenges in combination of both the modalities. We do not know the optimal treatment timing, whether we can improve from the current standard of care. We do not know whether the fractionation of radiation or dosage can differ when we are combining this with immunotherapy. We do not know about the radiation-induced toxicity. And maybe we could find better biomarkers in future, which can define which patient would do better with combination of immunotherapy and radiotherapy. And whenever we are using any agent in the concurrent setting, we are using that as radiation sensitizer. So could immunotherapy be a radiation sensitizer? There's no clear evidence as of now, but yes, it is a possibility. There are some indirect evidences, like P53, which is a radiation response regulator, also modulates PDL1 expression. And the immune checkpoint blockade may influence the tumor microenvironment by regulating cytokine secretion and by remodeling tumor vasculature. So with this, end my talk. Thank you.